Today we're going to talk about Hayek and BCV, and can BCV help the patient with advanced COVID-19 respiratory illness, and how? Mission report suggests that the COVID-19 is associated with severe disease that requires intensive care in approximately 5% of proven infections. The most documented reason for requiring intensive care has been respiratory support, of which two-thirds of patients have met criteria for acute respiratory distress syndrome. The exact cause of death is unclear at this point, with progressive hypoxia and multi-organ dysfunction being presumed causes. This from Care for Critical Ill Patients with COVID-19, JAMA-network.com. So with BCV, one of the questions, of course, with supporting these patients is the generation of aerosol particulate in the nearby environment, and the individual who has active COVID-19 carrying on that contamination through that aerosol distribution, which can be increased with certain types of support devices that may increase that aerosol distribution. With BCV, there is no additional production or spread than there would be with the patient breathing spontaneously. In settings with limited access to ventilation prior to patients developing severe hypoxic respiratory failure, there may be a role for high flow nasal oxygen or non-invasive ventilation. However, there is some consideration that these two techniques can actually contaminate the environment with aerosol. And with BCV, the patient could potentially wear a protective mask and decrease the spread into the environment. But certainly, when the patient has been breathing spontaneously and then BCV is started, there's no additional spread of aerosol particulate into the environment than there would be had the patient continued to breathe spontaneously. With BCV, we have advanced for some time an open lung concept for treating acute respiratory failure and ARDS. And the foundation of that concept is that negative lung inflation optimizes lung volume by recruiting and stabilizing unstable airways and lung units with negative lung inflation. You get the most homogeneous possible distribution of ventilation with that type of inflation, which results in benefits of improved pulmonary compliance, improved gas exchange, decreased work of breathing, secretions flow better from the deep regions of the lungs, increased shunt and dead space, and improved pulmonary perfusion. Now, the criteria for acute or acute on chronic respiratory failure are fairly simple. They vary slightly depending on who is setting them out, but they are basically similar across the board, and that is a PO2 less than 60 or a pulse oximetry reading of less than 91% with the patient breathing room air, or a PCO2 greater than 50 if the pH is less than 7.35. That's hypercapnic acidosis. pH particularly fully compensated if the patient is chronic and advancing to stable and unstable with increased symptoms, or P to F ratio falling below 300, or PO2 decrease or PCO2 increase by 10 millimeters from baseline if known. Okay, this is from an article that was published in Pulmonary Pharmacology and Therapeutics in 2017. They looked at 8 patients with severe COPD exacerbation and exacerbated chronic respiratory failure in a setting of intermediate intensive care unit. These patients received an interesting type of support, and it showed pretty clearly that they benefited. They used a combination of mask ventilation and BCV. The findings of this study were gas exchanges were significantly increased compared to the 2 support methods used singularly. All patients tolerated the application well, and they found the use of dual mode ventilation appears well tolerated and superior to the individual modes of patients with COPD exacerbations and acute respiratory failure. So BCV is not only an amazing and very effective non-invasive means of support as a standalone device, but it offers potentials when it's combined with mask or invasive ventilation. So just something to consider. BCV has an awful lot of advantages when used in combination with other devices. So this is a paper, Grasso et al., Negative Pressure Ventilation and Lung Injury. The title of the paper was Negative Pressure Ventilation, Better Oxygenation and Less Lung Injury. Rationale for what they were doing was that conventional positive pressure ventilation delivers pressures to the airways. In contrast, negative pressure is delivered globally to the chest and abdomen. They wanted to test the hypothesis that ventilation with negative pressure results in better oxygenation and less lung injury than positive pressure. They utilized animal models. Surfactant depleted rabbits were ventilated for 2.5 hours in pairs. One got positive, one got negative. Tidal volume was used at a known injurious level of 12 milliliters per kilogram, and normal capnia was maintained throughout on a FiO2 of 100%. One of their basic findings is one that is not so surprising, that in healthy lungs with normal compliance factors throughout, transpulmonary pressure creates tidal volume. Whether the transpulmonary pressure is negative or positive in healthy lungs, that same transpulmonary pressure is going to create a similar tidal volume. So it doesn't matter whether lung inflation is negative or positive if we are taking care of an individual with healthy lungs. However, when the lungs grow sick, it's an entirely different picture. Lung inflation is maldistributed due to heterogeneous lung obstruction and injury patterns. And that is exaggerated more so when lung inflation occurs with positive pressure than negative pressure. The same volume exchange with positive lung inflation creates more lung injury than negative lung inflation. And they found that the same volume exchange with negative lung inflation results in better oxygenation. Further in the study, they looked at 5 experimental series, one with lung injury and oxygenation, series 2 was global pulmonary perfusion, series 3 was regional pulmonary perfusion, series 4 transpulmonary pressures, lung volumes, and oxygenation, and series 5 they looked at distribution of ventilation with CT scans. In series 1, they found that with negative lung inflation, oxygenation was significantly better. Also, they found that there was a significantly decreased gradient between arterial and end-tidal CO2, indicating decreased dead space ventilation with negative pressure. And the composite histologic lung injury score was significantly lower in the negative pressure group. Here's a graphic of the overall lung injury scores, significantly lower when lung inflation was negative pressure. A graphic of the PaO2 of the subjects. You can see initially they were quite similar in the mid 400s, decreased dramatically upon surfactant depletion, and then resumed back to almost near normal or the near starting 400s post surfactant depletion and initiation of ventilation. However, the open dots are negative pressure ventilation. And you can see significant difference once ventilation ensued between the positive pressure group falling almost throughout the entire study period below 100 and the negative pressure group that came up to about 300 once ventilation ensued and gradually increased over time up to over 400 again. The global pulmonary perfusion, they looked at a separate group of subjects for this. You can see one group of subjects was ventilated with a whole body device or a tank type device. The other group of subjects they looked at with a chest only device, more like a cuirass, and found that there was a significant improvement in pulmonary blood flow when the chest device was used. One of their findings from series 3 was that the cuirass could conceivably augment right ventricular preload, thereby increasing lung perfusion and improving oxygenation. This is something that's been borne out in many cardiac studies throughout the world. Okay, series 4, looking at transpulmonary pressures, they found that the transpulmonary pressure generated by negative end expiratory pressure was consistently less for a comparable level of PEEP. So end expiratory lung volume is maintained with less transpulmonary pressure when it's negative than with positive. For given levels of transpulmonary pressure, the overall index expiratory lung volume was greater with negative versus positive. And for a given level of index expiratory lung volume, the resulting PaO2 was greater where index expiratory lung volume was created with negative pressure versus positive pressure. So negative pressure, same pressure will gain a better PO2 than positive. Their CT scans showed them something that they found striking, and this is a quote from the article. The spatial differences were striking, with dependent atelectasis persisting over most of the side. Such patterns have previously been reported in patients undergoing positive pressure in the setting of acute lung injury. In contrast, with negative pressure, they observed a different topographic distribution in which normally aerated lung volumes were greater and atelectasis was reduced. So a significantly different distribution when the lung is inflated with negative pressure. The negative pressure pulls gas out much more evenly throughout all lung regions, sick lung units and healthy lung units, much more evenly distributed. They found that in the current study, the findings in the current study are similar to altered distribution of lung has been demonstrated in ventilation in the prone position. So this is our first encounter with some comparison of the lung inflation pattern created with a negative pressure lung inflation to the lung inflation pattern that we find in proning. This is a graphic of the aeration and atelectasis throughout the respiratory pattern. The first one is the percentage of the lung that was atelectatic. You can see a much larger percentage of the lung was atelectatic with the dark squares showing that, the open squares showing less atelectasis throughout the respiratory cycle for BCV. And the other graphic, that is the percentage of aerated lung and significantly greater across the entire study period for negative pressure. They found clinical implications of any approach that improves oxygenation or diminishes lung injury are very great. And they concluded that use of or incorporation of negative pressure should be reinvestigated in the clinical context in which oxygenation is problematic or lung injury is likely. Okay, just a case study. This is an individual that we have encountered in the past and was able to show a significant difference on in quite a short period of time. It was an 84-year-old male who had laryngeal cancer and had wound up in the ICU due to pneumonia, atelectasis, subsequent to a right apical mass. This is the event as it went. I was called over to the view box by an intensivist who asked me to see if I thought maybe our device would be able to help this individual. And on reviewing it, I offered that we could try. That BCV has been able to pull gas beyond obstructions for me before. And he said, okay, well, go ahead, X-ray will be here in 3 hours. BCV was started with continuous negative as a recruitment maneuver on top of the patient's positive pressure settings, which was CPAP and pressure support, although he could not wean beyond that level of pressure support. So BCV started -30 to begin the lung recruitment, and then secretion clearance treatment was applied for about 35 minutes, bringing up large amounts of dark beige sputum. CNEP was resumed again at -20, which was carried on for about an hour and a half. Secretion clearance treatment was repeated again. Again, large volumes of sputum, less dark. The patient was maintained in continuous negative at -28, pending the afternoon X-ray. This X-ray that you will see, the pre and post, although they're not great techniques, and it was actually snapped off the view box, but you can see significant difference in just 3.5 hours from beginning to end. And this is a patient in whose record it indicated they had not been able to pass a bronchoscope beyond the obstruction. So here is the pre-X-ray, and you can see significant atelectasis. And here we are 3.5 hours later. This is not following a bronchoscopy. This is following the use of BCV with aggressive continuous negative and aggressive secretion clearance on top of the patient's ventilator, positive pressure ventilator settings. So let's talk about P to F ratio a little bit. P to F ratio is often used as a guidance for determining the intensity of the respiratory failure or the ARDS. In respiratory failure, P to F ratio less than 300 is equivalent to a PO2 of about 60 on room air. P to F ratio less than 250 is equivalent to about 50 on room air, and P to F ratio less than 200 is equivalent to a patient on room air having a PO2 of around 40. That would be extreme respiratory failure. This is a poster that was presented at a conference in Japan, and from this we've gleaned quite a bit of very good information. So a little bit closer look at some of it. This paper was the role of biphasic QROS ventilation in acute respiratory failure, which was a retrospective review of 41 cases of patients with respiratory failure who were ventilated with BCV at this hospital in Japan. From various sources, including a patient with ARDS who developed a VAP, they were unable to clear the lungs with bronchoscopic suctioning, and BCV with secretion clearance was able to recruit that patient's lung. CNEP, they also found, was able to prevent intubation for their COPD patients due to increased work of breathing and dead space ventilation. Okay, and within this study is an example of some amazing alveolar recruitment. This was the individual that they weren't able to clear the lungs with the bronchoscope. 84-year-old female, aspiration pneumonia, and you can see the significant difference that secretion clearance made for this atelectasis. This is a breakdown of the types of patients that they cared for within the 41. Interesting was that the atelectasis and the acute cardiogenic pulmonary edema patients all were able to be managed on BCV alone. And additional information from their paper on the types of patients and the PaO2 increase that was seen across the board on each one. And they found BCV worked supportive for lung recruitment. Extrathoracic negative pressure seems less hyperinflative to non-dependent lung areas. Secretion clearance mode is often effective to prevent or treat postoperative atelectasis in patients with increased production of secretions. In this paper, non-invasive negative and positive pressure ventilation in the treatment of acute on chronic lung injury, it takes a little bit different look. They had 258 patients with acute respiratory failure on chronic respiratory disorders. 77% were treated exclusively with various forms of non-invasive ventilation, which were negative pressure ventilation, non-invasive positive pressure ventilation. So either one was able to be used, and then if the clinicians felt it would benefit, they would use the sequential use of both. When one type failed, they would attempt the other before moving on to more aggressive care. And they were able to utilize that type of approach in 14% of their patients. So in patients where negative pressure or non-invasive positive pressure failed, the sequential use of an alternative technique was allowed. And when this type of care pathway was utilized, the failure rate of the non-invasive means of support, when it was negative pressure ventilation initially, they were successful 23.4% of the time, or they failed 23.4% of the time, and then that decreased to 8% if an attempt at mass ventilation was made after the failure of negative pressure. By the same token, failure of non-invasive positive pressure was about 25%, and when negative pressure followed that type of support, if it failed, it brought intubation rates down to 5%. Hospital mortality was much lower than was estimated by the Apache 2 scores for these patients. And the conclusions of this paper were using negative pressure and non-invasive positive pressure, it was possible in clinical practice to avoid intratracheal intubation in the large majority of unselected patients with acute respiratory failure on chronic respiratory disorders. The sequential use of both modalities may increase the further effectiveness of non-invasive mechanical ventilation. So that's respiratory failure from its sort of various angles. Certainly, we don't have a specific item on COVID-19 respiratory failure patients. But the success that BCV offers and the PO2 and the ventilation benefit that it offers certainly has a high potential for being able to offer some really strong benefits to these patients. If the respiratory failure advances into ARDS, we have some things to offer in that area as well. Speaking on ARDS here, it's a life-threatening lung condition that prevents oxygen from getting to the lungs and blood. It can also occur in infants. Depending on the amount of oxygen, ARDS severity is classified as mild, moderate, or severe. ARDS leads to a buildup of fluid in the alveoli. This fluid prevents oxygen from passing into the bloodstream. The fluid buildup also makes the lungs heavy and stiff, decreasing the lungs' ability to expand. The level of oxygen in the blood can stay dangerously low, even if the person receives oxygen from a ventilator. ARDS often occurs along with the failure of other organ systems such as liver, kidneys. Poor health habits, cigarette smoking, and alcohol use may add to the risk for its development. So the prognosis for patients with ARDS is about a 1/3 or so will die from the disease. Those who live often get back to their normal lung function, but many people have permanent, often mild, but permanent lung damage. Many people who survive ARDS have some memory loss from the time during which they were treated in the ICU. This is due to brain damage that occurred when the lungs were not working properly and the brain not getting enough oxygen. Also, it's very stressful for the patients that have to go through the great difficulties that occur in the ICU for these patients with the many different aggressive interventions that they have to experience, the proning and the many different other things that they're going to have to go through, chest tubes and chest tube insertions should that occur, creates a potential post-traumatic stress for these patients. So ARDS severity, mild, we would say would be a P to F ratio between 2 and 300. Within the mild range, mortality is around 27%. In moderate will be 100 to 200, and the mortality in that range is close to a third of the patients. And then the severe ARDS, where the P to F ratios dip below 100, would have a mortality rate nearly of 50%. Acute respiratory distress syndrome, possible complications. Ventilator-induced lung injury is always a significant risk with patients once they're intubated and put on positive pressure. Other problems that may result from ARDS would be organ system failure. As mentioned, ventilator-reduced lung injury, pulmonary fibrosis, ventilator-associated pneumonia, post-traumatic stress. Patients could be unweanable and require prolonged mechanical ventilation. And with this pathology, there's a high mortality rate. So alveolar instability and collapse in ARDS result from inflammatory changes as well as from loss of surfactant function. And just sort of an aside, positive pressure actually does not enhance the function of surfactant. That's a fact. These changes plus edema formation from increased permeability produce right to left shunting of blood and ventilation perfusion mismatching. Both produce severe hypoxemia. Pulmonary hypertension occurs commonly in ARDS due to vasoconstriction, thrombosis, perivascular edema, inflammation, eventual interstitial fibrosis, hypoxemia, hypercarbia, both lend to increased alveolar perfusion pressures. Overt right ventricular failure may develop if pulmonary hypertension is severe and prolonged. Although reported ARDS mortality rates today are less than 30%, recovery is often complicated by superimposed infections, hyperoxic injury, ventilator-induced lung injury, barotrauma. Even with recovery, lung fibrosis may result in irreversible lung dysfunction. ARDS is sometimes classified as primary or secondary. Primary ARDS describes lung injury from a direct insult, for example, aspiration. Secondary ARDS describes lung injury as a part of the systemic process. The lung is one of many organs injured by a systemic inflammatory response, such as sepsis. So with BCV, we offer something different. If BCV is applied when acute respiratory failure is recognized, when that P/F ratio begins to fall to the 300, the low 300s and beyond 300, when you're recognizing that we're beginning to have that type of insult go on, if we can apply BCV from that point through to the resolution of the illness, it offers injured lung the least chance of further damage and the best chance to recover as quickly as possible. BCV can be used effectively to enhance results in combination with other therapies. You can use with continuous or intermittent nebulization. BCV opens the bronchiolar targets so you can deliver more drug to the area where it can make the most difference. With high flow oxygen and high VNI therapy, BCV is an amazing tool. Combined with those devices, you can use it, as we've seen, with mask, non-invasive positive pressure ventilation. It can combine with heliox. It combined with positive pressure ventilation in any mode, either through the use of continuous negative, as we described previously, or the two devices can work together in sync to augment ventilation like a few other combined devices possibly can. Can work with high flow oscillatory ventilation to decrease mean airway pressure. Can work with ECMO to keep the lung inflated throughout the ECMO process and to augment or increase the potential of damaged lungs to be able to be reinflated safely. Another case study from patients that we've encountered, this was a 56-year-old male, morbid obesity, had been a chronic PTOH user, was admitted with altered mental status, severe liver disease, peritonitis, and possible ileus. His chest x-ray showed severe right lung atelectasis with infiltrates and effusion. When I encountered him, he was on positive pressure at a sys control of 25, PEEPA 15, 100% oxygen. His oxygen saturations were in the low 80s, his P/F ratio in the low 60s. The intensivist was requesting BCV with a goal of improving oxygenation. We were able to begin BCV. He required the largest size shell, size 10, and we were able to apply continuous negative of -20 on top of his standard positive pressure settings. After 14 hours on BCV, his O2 had weaned from 100 to 50%. His oxygen saturation had come from the low 80s on 100% to the high 90s on the 50%. And a series of ABGs shows him progressing through this time. And the down and dirty is his P/F ratio increased from 64 to 177 after 14 hours of use of continuous negative of -20 on top of his positive pressure ventilation settings. The AADO2 went from 596 to 277. This is a paper that came in Critical Care in 2012 about 6 patients who were monitored on negative pressure and positive pressure ventilation for 2 hours each. Both groups received 6 milliliters per kilogram, and ventilation was controlled for equal index expiratory lung volume. Negative pressure was found to result in better oxygenation compared to positive pressure in these patients with a mean P/F ratio of 345 versus 256. Negative pressure lung inflation, airway pressures were considerably lower at inspiration, a negative 1.5 at the airway versus 34.5 with positive pressure. During negative pressure, intra-abdominal pressures decreased from 20.5 with positive pressure ventilation to 1 millimeter of mercury. The conclusions were negative pressure improved gas exchange in patients with ARDS at lower transpulmonary pressure, airway, and intra-abdominal pressures. This paper looks at combined negative and positive pressure ventilation for the treatment of ARDS in a single case paper on a 75-year-old male with ARDS that was unresponsive to high PEEP. This paper reports that they used external negative pressure ventilation combined with conventional pressure support using a PEEP of about 8 and a pressure support of 4 to 12. After initiation of negative pressure, alveolar infiltrates disappeared rapidly. P/F values surpassed 300 after the first application/recruitment maneuver and 500 after the second. Negative pressure ventilation was used for 6 to 18 hours per day over 5 days. This is the first day changes that were reported for the x-rays. The possibility of effectively applying this and similar concepts, this paper found, not only in intubated but also in non-intubated patients with ARDS offers new options that may genuinely differ from the present therapeutic approaches. Therefore, these options may have the potential to decrease the ongoing high mortality rate associated with ARDS. This paper, it talks about use of certain positive pressure ventilation techniques to basically what they term stent or cast the lung into an open state. And their foundation finds some very basic information. The lung is designed to function optimally only when inflated, and thus the ideal situation would be to cast the lung and let it heal in its biologically natural volume. Studies have shown that elevated airway pressures of a level known to cause ventilator-induced lung injury is relatively benign if the lung is not allowed to fall significantly below FRC. They found that maintaining adequate FRC has been shown to be protective in the normal lung. Ventilator-induced lung injury mechanisms are associated with a loss of expiratory lung volume and stability. And they find that opening and stabilizing alveoli would prevent the primary mechanisms of ventilator-induced lung injury. Progression to ARDS is often silent with normal blood gases in the presence of ARDS with unstable alveoli, leading clinicians to believe for a period that things are fine. By the time this level of lung pathology that demonstrates compromise is there, there's already considerable tissue damage and surfactant damage, resulting in a significant loss of lung volume, predisposing the lung to lung injury. Their finding is to never give the lung a chance to collapse, and by doing so, eliminate most lung injury pathology. Well, we take a little bit different approach to the same end, less invasive perhaps, but we believe you can open the lung with BCV at the recognition of potential onset. Use continuous negative or highly negative control mode settings to guard against that loss of FRC. Use extrathoracic lung casting, initiated at early signs of respiratory distress to prevent lung contracture and prevent illness escalation that would be resultant from the loss of FRC and the atelectasis that goes with it. Extrathoracic lung casting can be maintained throughout mask to intubation and positive pressure ventilation, potentially shortening the duration and lessening the intensity of illness in positive pressure settings. The goal would be earlier extubation and more rapid recovery for a larger number of survivors. This is another paper that demonstrated use of BCV, a bit of a unique approach. They looked at it as use for something called continuous negative abdominal pressure, and they found that some of their obese ARDS patients had severe intra-abdominal hypertension, and by applying BCV abdominally and applying a continuous negative, they were able to relieve that elevated intra-abdominal pressure. They were able to improve pulmonary mechanics by decreasing that abdominal pressure as well and enhance ventilation for these patients. And that reference is here in the presentation. I'm not going to read the whole thing, but it seemed to be a good result for that patient, improved atelectasis, and benefited the open lung. And this is a reference to one of those papers. Continuous negative abdominal pressure recruits lungs at lower distending pressures. In this paper, they found ventilator-induced lung injury and acute respiratory distress syndrome occurs mostly in ventilated, non-dependent lung regions termed the baby lung. Recruitment of dependent atelectasis involves transient elevation of airway pressures. When we're talking positive pressure, transient elevation of airway pressures to increase the size of the baby lung and reduce its susceptibility to injury from inspiratory stress. Clinical studies of these techniques, however, have resulted only in marginal benefit, possibly because increased airway pressure first overinflates and potentially injures already aerated regions of the lung that has atelectasis. Abdominal pressure, they found, is a key factor that increases the propensity to dependent atelectasis. Negative pressure applied outside the abdomen can lower intra-abdominal pressure in patients and could potentially decrease dorsal atelectasis by caudal shift to the diaphragm. Negative pressure pulls gas preferentially to the to the dorsal regions of the lungs. It's an entirely different inflation pattern, and that was demonstrated here with the peak benefits and transpulmonary pressure benefits, which we're not going to go into all the details of this, but it's worth looking closer at in the citation. These are CT slices showing significant improvement in aeration with PEEP at 6 centimeters and continuous negative abdominal pressure. Continuous negative abdominal pressure mechanism of action in comparison with prone positioning. Here is another look at a comparison to prone positioning. This paper was from a group. They say they recently reported continuous negative abdominal pressure could result in recruit dorsal atelectasis in an experimental lung injury, and that oxygenation improved at different transpulmonary pressure values compared with increase in airway pressure. The mechanism of recruitment with continuous negative abdominal pressure is uncertain, and its impact compared with a commonly proposed alternative to recruitment prone positioning is not known. They hypothesized that continuous negative abdominal pressure recruits lung by decreasing the vertical pressure gradient, which is the different pressure requirement to inflate dependent and non-dependent lung regions, and that was one of the mechanisms of action of prone positioning. Continuous negative abdominal pressure was found to lower the pressure in dependent but not non-dependent lung, and therefore, in contrast to PEEP, it narrowed the vertical pressure gradient. Continuous negative abdominal pressure increased respiratory system compliance and oxygenation and appeared to selectively displace the posterior diaphragm hollow on CT images. Compared with prone position without continuous negative abdominal in the supine position was associated with higher arterial partial pressure of oxygen and compliance, as well as greater homogeneity of ventilation. The mechanism of action of continuous negative abdominal pressure appears to be via selective narrowing of that vertical pressure gradient and appears to offer physiological advantages over prone positioning. The article's new and noteworthy section stated that continuous negative abdominal pressure reduces the vertical pressure gradient in dependent versus non-dependent pleural pressure and increases oxygenation and lung compliance. It is more effective than prone positioning at comparable levels of positive end expiratory pressure. PEEP alone did not result in lung recruitment, whereas PEEP and continuous negative did open a significant volume of lung, especially in a diaphragmatic lung region. The conclusion was that continuous negative might be a potential adjunct to PEEP in the recruitment of diaphragmatic atelectasis. So BCV for ARDS, we know there really has not been any major improvements in mortality since the ARDSNet low tidal volume ventilation studies. That seems to be, from my observations, sort of the middle of the road right now as to how we're using positive pressure to treat these patients. There are some variations on each side of that, but in general, the positive pressure ventilation strategies for improving results in ARDS have run their limit. There's very little else that we can do with positive pressure that will enhance this result. However, with BCV, we offer oxygen and compliance benefits that come from restoration and maintenance of the natural normal level of FRC. BCV improves the P to F ratio. Throughout papers on every patient group, you will find improvements in oxygenation are shown by applying negative pressure for lung inflation, whether in the continuous static mode or in the biphasic mode. P to F ratios, oxygenation, very typically improve when this is applied. BCV increases the FRC. One of the primary goals of all respiratory therapy approaches is to restore normal FRC. BCV does this non-invasively, comfortably for the patient. Work of breathing, when normal FRC is restored in almost any type of respiratory distress, work of breathing decreases, sometimes extremely dramatically, when a patient has their normal FRC restored with negative pressure. BCV supports the cardiac function. Other types of supports, positive pressure for respiratory failure in ARDS, we all know has the potential of compromising cardiac function. The thresholds at which positive pressure can negatively affect cardiac function are different for every individual patient. But we know if we apply enough positive pressure long enough inside the thorax, less blood will come back to the heart and less cardiac output will occur. That is not an effect at all with negative pressure. When you support the lungs with BCV, you're also supporting the heart. BCV supports portal, renal, and GI system perfusion. When the body is in crisis, blood is shunted to the primary organs, the brain, the heart, and the lungs, and is shunted away from the abdominal organs. Also, positive pressure inside the thorax is going to decrease perfusion of these other organ systems, adding to the potential for additional inflammation processes occur due to decreased perfusion. BCV, in the papers that we have, shows that organ system perfusion is increased with the use of negative pressure as a means of support. So BCV gives you better oxygenation, less potential injury to the lungs. It works well should you need to use it in combination with all types of fly flow oxygen, non-invasive positive pressure, mask ventilation. Positive pressure invasive ventilation can be used with ECMO and provides better results for patients with ARDS. Thank you very much.